Hi, everyone. Sorry for the delayed start, but thank you all for coming. And welcome to everyone in the room and to those joining us online to this panel entitled Better Humanitarian Responses to Sexual and Reproductive Health and Rights, or SRHRs, you'll hear us say many times, in crisis settings. My name is Megan Daigle. I'm a senior research fellow and gender lead with the Humanitarian Policy Group at ODI, a global affairs think tank based in London with offices and a growing presence here in Brussels. Today, this panel of experts will explore the responsibility of humanitarians when it comes to the SRHR needs of crisis-affected people. We're starting today from the contention that under international humanitarian law, humanitarian access should be understood as providing for SRHR services. And furthermore, that such services are critical for supporting health and reducing harmful outcomes without adverse distinction and as a part of an impartial and neutral approach that leaves no one behind. From various perspectives, each speaker today offers their own reflections on progress to date and remaining challenges, barriers, and potential enablers for building this kind of access. Drawing on a wealth of expertise from years of practitioner experience in direct health service provision, coordination of services and program design and delivery, and research on SRHR needs, services, and barriers, and also drawing on policy work in forums like the High-Level Commission on Reproductive Justice, which was formed after the 2019 Nairobi Summit and hosted by UNFPA, and emphasizing throughout that full and unimpeded access to SRHR is a prerequisite to effectiveness and impact. I want to start by thanking our co-hosts for today's event, the Feminist Humanitarian Network, the International Planned Parenthood Federation, UNFPA, and Irish Aid. So first, I have the pleasure of introducing our opening speaker, who will offer some framing remarks before we turn to the panel. Nicole McHugh is the Humanitarian Director at the Development Cooperation and Africa Division of Ireland's Department of Foreign Affairs. Her career in the Department of Foreign Affairs has spanned 20 years, during which she has managed a number of development programs and led on policy development in relation to key aspects of Ireland's most recent international development policy, led on Ireland's engagement from headquarters with the OECD DAC and Ireland's chair of the Nordic Plus group. Nicole, would you like to?
Yeah. I think I'll maybe pull up a pew. Great. So, very loud. Good morning, everybody. It's really a pleasure to be here, and thank you so much to HPG for organizing this really critical discussion. I'll be brief because I think everybody would like to hear from the experts on the panel. But just to say, HPG is a really valued partner of Ireland, not only because of your incredible work, but also because you listen to the perspectives of people living in crisis-affected settings and bring evidence to the table, which is really important for us. We, as Ireland, have a clear commitment in our development policy to supporting SRHR in emergency settings. We also have a very clear commitment to gender equality. Of course, in terms of our history, even though we've always been a strong advocate of gender equality, we were limited in the past in our ability often to highlight the particular role of SRHR in gender equality. But through a key domestic process of political engagement, legislative change, and social policy change on a range of sexual and reproductive health issues and rights discussions, we've been able to now have a much more robust and influential policy engagement. As you know, internationally, of course, things are not always progressing so well, and we've seen a very disturbing rollback in terms of women's and girls' rights, as well as the rights of minority groups. So it's more important than ever now to join hands and to redouble our efforts to ensure that SRHR services are available to all crisis-affected peoples. I'm just going to make four really brief points. Firstly, and it might be stating the obvious, but this really does need to be said, the provision of SRHR services is life-saving. It's not an optional extra. It must be planned for and be part of every humanitarian response. If we don't prioritize SRHR, we are guilty of not only denying crisis-affected communities access to essential services, but of altering their future for decades to come. Secondly, in the current context of escalating humanitarian needs and funding gap, and we've heard a lot about that over the last day and a half, the need for the donor community to advocate for and provide dedicated funding for SRHR is more important than ever. The data speaks for itself. There's no need to wait. Ireland allocates approximately 60 million euros every year to SRHR. In our emergency responses to Ukraine and the Horn of Africa in 2022, for example, we allocated funding to partners with specific expertise in this area. It's not only about the funding, of course, it's about the advocacy, and we have committed to be a vocal advocate for the advancement and protection of SRHR, and this was a key priority for Ireland during our term on the UN Security Council, and we continue to do so in our women, peace and security work, and also working through our partnerships. Thirdly, again, we've heard a lot about access in the conference, in the forum over the last day and a half, and in conflict-affected settings, reaching those most in need with SRHR services is increasingly compromised by a lack of respect for IHL. And we see this play out on a daily basis in Ethiopia, in Myanmar, in Yemen, and other places, and unfettered humanitarian access is really the prerequisite to the delivery of impartial humanitarian assistance. I'd be really interested to hear from the panel as to what your experiences are in terms of access and how this affects your work on the ground. And fourthly, my final point is really about how we deliver SRHR services. So as a donor, we firmly believe it's the kind of funding that we deliver, not just the volume of funding. So quality funding is very important to us. Being able to listen to the evidence and good practice on the ground to see change is critical, but change happens over time. So what helps with this is longer term planning, programming, flexible funding, multi-year funding, and Ireland continues to lead in this space. 90% of our funding is now flexible and over half is multi-annual. There is, of course, more to be done, and I really look forward to hear from you today on what needs to be strengthened and how Ireland can support. And just on a final word, I mean, what really struck me listening to some of the sessions was that the most critical and useful communication tool really is to hear people's stories. I think we all need to allow women to be able to tell their stories and give women access to platforms where their voices can be heard. Thank you.
Thank you so much, Nicole. So now I have the great pleasure of introducing our panel, but unfortunately we're starting with some apologies. We were meant to have Dr. Ulfat Mahmoud from the General Director of the Palestinian Women's Humanitarian Organization in Lebanon, but Dr. Mahmoud's visa was not approved in time to attend. She also planned to join us virtually, but she's fallen ill. So we send our best wishes to Ulfat for a speedy recovery. I'm going to introduce her anyway, because she's been a very valued partner to us. Ulfat is a qualified nurse with a focus on community nursing and experience with the Palestinian Red Crescent. She holds a PhD in psychology and is an activist for Palestinian women and girls. Her organization is currently partnering with HPG on some USAID-funded research on barriers to SRHR in Lebanon for diverse populations. She's also a steering committee member of the Feminist Humanitarian Network, one of our co-sponsors. I'm going to abuse my position as moderator for a moment to tell you a little bit about that research, which she was going to discuss with you today, and which some of our other speakers are kind enough to support through our steering committee. The first output from that research is actually already available. It's a report on reproductive justice as a new framework for understanding and approaching SRHR in crisis settings. It's available online, and I will point anyone who's interested to it. Our primary research in Lebanon is now wrapping up, and we're collecting, as Nicole said, stories from people of all genders, abilities, and nationalities of their attempts to access SRHR and the barriers they encounter. And I'm going to quickly share 4 early findings from that. Our first finding is around an outsized role for negative perceptions and attitudes from SRHR service providers along pathways to access. Participants are reporting stigmatization on the basis of their refugee status, their gender identity, their age, and their marital status, particularly around ideas about who should be accessing SRHR. And this brings important implications, not just for whether and how they access SRHR in future, but whether and how they engage with health systems at all in the future. Secondly, delays and refusals of services are characterizing a lot of the experiences, and this is linked to attitudes as well as availability and begs questions about what happens next when people can't access services, and especially illicit pathways. Third, it's clear that vertical silos around SRHR, but also around GBV and mental health and psychosocial support are compounding traumas and harms. Holistic approaches are very thin on the ground. And finally, our partners are reporting that humanitarian response seems to be mostly invisible in the stories collected thus far, and especially for Syrians and Lebanese people. So we're already thinking through implications of these findings for the relationship between needs and rights, for how we can energize support for comprehensive SRHR and reproductive justice, and how we can equip humanitarian champions, like I hope everyone here, to make that case within their organizations and their networks. So I'll relinquish my hold on the mic now, but first I'm going to introduce Dr. Nahid Toubia. Dr. Toubia is the director for the Institute for Reproductive Health and Rights in Sudan. She's a clinician and surgeon specializing in female genital mutilation and cutting, who has held advisory roles with the World Health Organization, UNICEF, UNFPA, UNDP, and Human Rights Watch. She also co-founded the Research, Action, and Information Network for Bodily Integrity of Women, or RAINBOW, and is affiliated with the Columbia University School of Public Health. And she's also a commissioner on the High-Level Commission on Reproductive Justice. Dr. Toubia, as a clinician and an advocate, can you give us a sense of the scale and diversity of needs related to SRHR that you've encountered in your career?
Hello, thank you, Megan. Thank you very much for having me here. I'm glad the room has both men and women in reasonably good proportion, because usually when we talk SRHR, we find that it's mostly women. But we need to engage everybody. I think in humanitarian settings, and in all settings, women come with their reproductive capabilities and their bodies, which is used in many situations as a field for struggle. So I think when it comes to humanitarian support, I want to start with the services and then talk about protection, and also talk about something very important, which is not to lose the opportunity of a disrupted environment. And I know that might sound a little bit, but I'll leave you there and I'll explain it in a little bit. First, we need to get to the immediate services we need. Women in humanitarian situations, and I also don't want to exclude minorities, but maybe we can talk about sexual and gender minorities a little bit later. But the majority of who needs the services, who are more vulnerable, are girls or women. So the immediate things we need to do is to make sure that they get the basic services. That is contraception to everybody regardless, because sometimes even those who are more protected become less protected and may need contraception. So I don't even want to call it family planning. I refuse to call it family planning anymore. It's the right to contraception. So we need to have that within the toolkit of the immediate emergency. Then, of course, there is antenatal care and safe miscarriages, safe abortion. We might not talk about that. But also then we need to talk about antenatal care and safe delivery. Now, I don't know why, but it seems like pregnancy continues even under the most adverse situation, because people continue to have sex no matter what. So these are the basics for services, and they should be non-prejudiced, they should be available to everybody, they should be of the best and highest quality possible. Now that can come from those who are providing just humanitarian services, or if the people providing humanitarian services are integrating with local service providers, and that's when sometimes you need to do retraining and also overcome some of the existing prejudices that are on the ground. So that's the emergence. The next, beyond services, there is protection. Vulnerability for those who are like women, but also all those who have compromised social existence, like gender and sexual minorities, increases immediately when people are displaced, where they're away from their more adjusted protection within whatever, even those who may be at the periphery of society, whether they're sex workers or LGBT, or of course the majority of women and girls. So I think that to be aware that there is an increase of vulnerability and put in place protection to avoid all forms, the whole range of gender-based violence is also very essential. So we have services and we have protection. I know I don't have a lot of time, and maybe I can put in more detail later when we're talking, but I want to take a few minutes just to emphasize something. As somebody who comes from Sudan, who lived Sudan in some of the most difficult periods, which is during 30 years of a fundamentalist military dictatorship. When we opened the Institute for Reproductive Health and Rights, and by the way, we call it reproductive, although we talk about sexual and reproductive health and rights. So we just dropped the sexual in the title because we wouldn't be able to register otherwise. We found that people who've been denied any information within this range or this area of thinking were crying for information when we started. So when we thought, okay, 30 years of fundamentalism, maybe people wouldn't want to hear that, but it was actually the opposite. People wanted to know. And here I want to talk about the opportunities even within humanitarian settings. What happens, I know it's horrible. Sometimes people's lives are disrupted, their livelihood, their families, sometimes even worse, disease, death. It's horrible. But there is a little bit of a light at the end of the tunnel, or the good side of the lighter side of the moon, not the darker side, which is when you have disruptions, traditional systems that sometimes in some ways oppress people or stop them, or poor services that don't allow women to know about their rights for contraception or all sexual rights even, get disrupted. And here is where humanitarian assistance can actually do something. It can use that disruption to actually bring in higher quality services, new ideas about rights. But you have to do it with the collaboration, with the empowerment of the people who are on the ground. And I don't mean the service provider and the protectors only, but the women themselves. To give you an example of that, I was in Sudan 3 weeks ago. And what I realized that as horrible as the Darfur situation that has been, I wouldn't even call it crisis anymore, it's been going on for so long. Actually, there are so many women's organizations in Darfur now fighting for their rights. That may not have happened if Darfur didn't have the problems of Darfur. So what I'm trying to say is disruption is horrible, but it also opens up societies that are kind of well-balanced in their power control. It actually bursts out the power control. If we do it right, and if we engage the people on the ground, if we engage women, create spaces for them to start thinking, to start talking to each other, starting to realize that there is something beyond the periphery of their village, actually, you might be putting the seeds for something very much stronger long-term that will actually empower women and provide the kind of sexual reproductive justice locally driven in the long term. I just want to put it in very quick way, but there's a lot to be said of what disruption can do actually. Thank you.
Thank you very much, Dr. Tuvia. I'm sure there'll be many questions and lots to dig into when we get to the Q&A, but for now, I'm going to shift to Julie Taft. Julie is the Global Humanitarian Director for the International Planned Parenthood Federation. For more than 20 years, she's been a frontline provider and coordinated emergency health programs in numerous complex settings, including Afghanistan, Darfur, Ethiopia, Haiti, and Ukraine. So my question for Julie is, what is the current role of the humanitarian system and international humanitarian actors in providing and facilitating access to SRHR?
Thanks, Megan. And thanks for this opportunity to speak at this event. I think I first want to mention that IPPF is the largest sexual and reproductive health and rights organization in the world, and we have an enormous footprint. So we have over 118 members in over 140 countries. And year on year, about 40 to 50 of our members are responding to humanitarian crises. Some of these are protracted crises, and so this is their day-to-day usual business, such as in Syria, Palestine, Afghanistan. But others are new, either acute onset or slow onset, but also occasionally seasonal. And so our way of working is local. We are local. We are a network of civil society organizations who focus on sexual and reproductive health and rights. And I think that's really what is an important, I've been impressed, let me say, for the last 2 days in hearing varied reflections on the commitments around localization, around some achievements, around the continued barriers to it, and some concrete suggestions as to how we can continue to advance this work. But I wanted to touch on a few things related to this because it's part of the complementarity of the whole sector, of all of the stakeholders, of all of the humanitarian actors. But there's still a ways to go. And I only had 2 points, but because Nicole asked about humanitarian access, I'll speak very briefly to this. But I'm not sure that this is specific to SRH. But absolutely, we are seeing much more constrained humanitarian access in our operations. You mentioned Tigray, Afghanistan, Syria. We are seeing it more and more. And having those local actors who already have those existing relationships within those local communities at the local level, the municipal, the district, are absolutely essential to be able to leverage continued access and engagement with those communities and service. And we have seen that with our member association in Ethiopia specific to the Tigray crisis, where they were alone able to continue to provide essential services in various areas that no other actors were able to access. So I don't think that's specific necessarily to sexual and reproductive health, but it absolutely is something that is critical that local partners bring. The next two, I think, are slightly specific to sexual and reproductive health and how, when we talk about localization, it's a bit of an umbrella term. I mean, we have local actors, national actors. I think what I'd like to share is that there needs to be much more focus on civil society when it comes to sexual and reproductive health. It is the investment in civil society organizations that is going to move the needle and ensure that we are actually able to access those most vulnerable populations, the most stigmatized, the most discriminated against. Because it's not that there isn't enormous value in investing in governments. Absolutely, that is a needed investment that is critical for ensuring that we are delivering humanitarian aid, and that should continue. But if we're not focusing on the CSOs out there doing the work with the relationships embedded in these communities, we are not going to ensure that we're meeting all of the needs and of the sexual health needs, particularly of those ethnic minorities, of people living with HIV, of LGBTQI communities, of a variety, people living with disabilities, and other communities that are really marginalized. So I think that every time we hear an achievement or a goal around localization, we need to ask, well, where is that actually going when it comes to SRH? So that we know that we're moving that needle in that direction. I guess another point is that you cannot provide the full service package for sexual reproductive health if you are missing the rights element. You can't do it. You need to have those access rights. You need to have them in order to really provide the minimum initial service package as endorsed by the global community, by the Sphere standards, by the international, the interagency working group. And if you are lacking rights in those contexts, it is extremely difficult to provide those services. And specifically ones that come up again and again are access to emergency contraception or legal frameworks or policies that make access to sexual violence care more complicated, more difficult. Certainly access to abortion care. If we're not addressing these frameworks and policies at the nexus point, at the, across the continuum of work, then we're not going to be able to deliver it as effectively and with the impact that those in need deserve at that time. So I think maybe we'll get into discussion around this a bit more, but it's around that nexus work. It's around working with those activists and those civil society organizations along the continuum who are doing that important work. In order to ensure that those rights are in place. I just wanted to share two examples as illustrative. And one is around emergency contraception, which one might not think to be a particularly difficult thing to get in some places, but this actually comes from a European country who is receiving refugees from Ukraine, and speaking with a number of partners in this country about how do we ensure access to emergency contraception to those in need coming over from Ukraine. And in one particular forum, I was speaking with a woman who was 20-something, and she said, listen, I am a 20-something woman from this country. I speak the language. I'm highly educated, literate. I'm active in the sexual reproductive health space, and I don't know how I can access emergency contraception. This is shocking, right? And these are the policy and framework barriers that we need civil society organizations and local organizations who know how to work and navigate these policies and frameworks within their context to help us guide us on how to do this and to implement this. This isn't something people from outside can say, oh, try this, that, and the other. They'll know. There are networks who are working on these exact issues, and that's what's so rich and valued in terms of understanding how to work in the realistic barriers that many are facing. With that, I think I'll stop. Thanks, Megan.
Thank you so much, Julie. I'm going to turn now to our final speaker, Shoko Arakaki, who is the director of the Humanitarian Response Division in the UN Population Fund, UNFPA. Shoko has a proven track record in the field of humanitarian development, peace, and security. She brings over 26 years of diverse experience in leadership positions across different bodies of the UN system, including OCHA, UNDP, and the Department of Peacekeeping Operations, as well as international NGOs. So Shoko, how can donors, bilateral agencies, and implementing partners support countries and communities' resilience to ensure that quality SRHR services are available and accessible to the most vulnerable in the face of increasing humanitarian needs?
Thank you, Megan, and then thank you very much also, Nicole, and then the distinguished panel. And then good morning. I think I'm really delighted to see this topic is included for the humanitarian talk. Because UNFPA is, as you may know or you may not know, we are leading a coordination role on the SRH under the global cluster system, and then also the gender-based violence under the protection cluster. It's not easy. It's not easy to understand that the SRH is, part of life-saving, as just Nicole said. It's not nice to have. It's not luxury. It is indeed, life-saving humanitarian response. So, some of you may not know about UNFPA, just I have to simplify, our mandate is like, we have 3 zeros, and then ultimate goal, and then mandate of the UNFPA. One is the zero unmet family planning, 0 unavoidable maternal deaths, and then 0 gender-based violence, including harmful practice and including gender-based violence by 2030. So our mandate is sensitive, as you know, but this is something that let me just say that that there are many statistics and then also the evidence. But just one thing that I want to highlight here is that the more than 60% of maternal death and then more than 70% of gender-based violence happen in the humanitarian and fragile context. So if we don't do the SRH, humanitarian emergency delivery, we will never, ever meet the goal of the 3 zeros, and then also sustainable development goals. So I think, this is super important for all of us. And then also, more than 70% of affected population in a humanitarian emergency are indeed women and girls and children. And then so, I'm so glad that, it's few, but, I thought that I wanted to have, to see the more. And then you see the even plenary and the many speakers from the leadership, it's all men, and then only 3 for, the women. So this is, we have more work to do. So let me just, go back to the questions. I think, that there are like, 3 important or the critical pillars that we have to put into our perspective. We already talk about localization. We talk about, nexus. But, if something happened on the woman's body, it's too late. So it's not like, the things that you can fix immediately. So, the important things is the preparedness and prevention. So first pillar, I would really advocate and then promote and then preparedness. How we can have data, how we can have, how we can pre-position and then stockpiling all the commodities supply related to SRH kits and then emergency contraceptions and other, the supplies in advance to the emergency. And then third one is also supply chain management. And it's not just you stockpile, but you have to build resilient system of the supply chain to make sure that the supplies and then services to reach to the women and girls in the need and in an emergency. And then we need a workforce and midwives and then all of the service providers trained and then trained also the new, module and everything before the emergency. We have quite few good examples, in terms of preparedness and then Pakistan flood. And then we could really immediately, deploy some of the workforce to the disaster created by the flood last year. But also the financing and the budget. And then that's also important, to have the resources put in place before the disaster happen, because you can't really respond to the crisis and then women and girls and specific needs in a crisis if you're not prepared. And the localization in the sense that, the entire UNFPA's humanitarian revenue, it goes, almost 40% of the entire humanitarian revenue of the UNFPA goes to the women-led and the local organizations, including women-led organizations. So I think, that the women or the women-led organization should be part of preparedness planning, and then also the priority setting. But also, importantly, we have to, part of the preparedness, we really have to put the perspective, leaving no one behind, the marginalized groups, and then all of this group who may be left behind most of the time, they have to be part of it. Then I think, the nexus is very, very important. And then, gender inequality is really facilitate, the crisis already generated on the women and the girls. But it's so policy already said in a budget and all of the things, that we are talking about. But it's easy to say. But it's really, really difficult to put into the practice. And then we all talk about the nexus, but, very still conceptual level. And then, we really will have to translate this, how that means into the practice. But I think, Dr. Tobia mentioned, I want to really, present some of the good example, because, that we are all having so much devastating situation. I just came back from Haiti. So last week I spent some time in Haiti, and then I'm also going to back to Afghanistan within 2 weeks. And then, so there are a few good examples, I must say, because that's something that, we really have to put the light, to how we can replicate the good examples to deliver quality and then timely SRH services in an emergency. First, we talk about the Tigray. It was really, really systematized violence over the body of the women and the girls. And then once we start seeing all the displacement, and then we also start seeing the opportunity of a lot of midwives are displaced out of job. So UNFPA started actually hiring all those midwives who are displaced in the camp to start providing SRH and GBB services. They know the culture, they know language, they know the best, the context. So that's something ensure, the quality of the service of SRH and GBB services as an example of the Tigray. Haiti, and then also similar to Afghanistan. It's really difficult access issue, and then different type of the access. But the 12 facilities providing SRH and GBB service in Haiti, I don't know, some of you know the context of the Haiti. And then within, most of the facilities are under the gang control area. We don't pay to the gangs, different from the other agencies. And then in Afghanistan, and we have 200 facility, family, we call it family house facility. We don't use the language of the, the sexual, or you don't use the language of the gender-based violence. But it's still operating even within a white area where the Taliban has been there, before, the 20 years. Why? Because of community acceptance, community-based approach. And then, so that different type of the groups on fighting who are really blocking the access is actually agree to our approach. And then so this is something very important. That's something that we call actually the nexus in the practice. Because UNFPA has there like almost 50 years, and we have been working with the community. So I think that's the something that we continue as our the business model. But lastly, I know I talk too much, but I think the last example, I also want to, the opportunity, the disaster turned into opportunity, Rohingya refugees. I know this is really unfortunate that they become refugees, but some of the women say that they are actually, out of the crisis, they learned about SRH. If they wouldn't have been refugees, they wouldn't have never ever received the SRH and GBV services before. So I think, there are a lot of things that we can do more, and then within the difficult situation in the humanitarian crisis. But thank you very much, and then, I'm really much looking forward to any questions and then discussion today. Thank you.
Thank you, Shoko. So let's see if there's questions in the room, but otherwise, I certainly have some I could ask. And we might have some questions for each other. Does anyone want to jump in?
Can I ask something?
Of course you can.
We are clearly agreeing that on two things, I think. Number one, that essential sexual and reproductive health, and I use my words very carefully, services should be right at the forefront of any humanitarian response, whether it's an acute one, whether it's a slowly growing one. Essentials. I don't even know why we still today, 2023, talking about whether it's saving lives or not. It's absolute. Women come with their bodies, they're going to get pregnant, or we can help them not get pregnant by providing contraception, and not just emergency contraception, but the full buffet of quality, high quality contraception. Training of the healthcare provider, whether they are the emergency healthcare provider or it's an opportunity to train the local health providers, whether they're midwives, as you said, or doctors who may not have had enough exposure to contraception, antenatal care, and better care for women. But my question for IPPF, we all stress the other side, which is the involvement of local people, local communities, not only because it will give us better understanding of what to provide, but also it could be the long-term solutions as well, and the change that we are looking for, especially if it's spaces and guided by women. Does IPPF work with other civil society organizations beyond their members? And I think my personal experience hasn't been that great in that regard. So I want to challenge IPPF to see whether they actually reach beyond their members.
Thank you for that. Yeah, and absolutely, it's the sustainable approach. And most IPPF members or collaborative partners are not humanitarian actors in their, in their founding principles, or their, they find themselves in humanitarian situations. So, and then part of what we do from the secretariat level is to support them in the operationalization of that and the resource mobilization for that and all of these other things. We have so yes, we do work beyond our member associations in certain contexts and areas, and I think one example would be the Ukraine, where we did not have formal member associations in many of the affected countries because an affiliation with IPPF was not something that was going to serve them. And so while they were partners in a certain way, they were not formal members of the Federation, because that actually increased targeting of them in a constrained environment. So I think in the last year or so, we have been much more creative and open to identifying partners outside of our formal membership in humanitarian settings. I can say that we've made that commitment, and we've done that. And in our next global strategy, which just launched this year, there is also statements and commitments around expanding the Federation. What that looks like, whether it's different types of partnerships, affiliations that open up, is still yet to be clarified. But I think at the root of it, there is a commitment by the Federation, and that is spoken on behalf of the member associations who voted and endorsed the strategy, that ultimately it's meeting the needs of those affected populations. That's the goal. And the means by which we do that and the partnerships that facilitate that and that we can enable through that is something they're committed to exploring and supporting. Thanks.
Thanks, Julie. I'll ask a question of my own unless there's any hands shooting up in the audience. All right, so Julie already spoke a bit about the relationship between needs and rights in humanitarian speak or health and rights in SRHR speak. And this is something we've been thinking about a lot, that's a difficult question for a lot of humanitarians who consider themselves to be needs-based, to think about that rights component. But a lot of what you were saying, Julie, really spoke to that, and I think Dr. Tubia as well, about how we need to understand them as interlinked. And we've been thinking about this in our research, about understanding that a failure to support rights ultimately creates further needs. It makes us less effective, but it also creates risks and creates harm to people living in crisis settings. And so I'm wondering if any of you want to reflect further on bringing the rights approach into humanitarian SRHR.
I think the simple answer is just empowering local people, and particularly empowering the ones we want to support to ask for their rights. And I still again say women and girls are the biggest population without excluding other vulnerables. But other vulnerable populations are very important. But I think the majority of those affected are the women and girls. If we create spaces to provide them with the knowledge, with the services, and with the understanding, they will fight for their rights. That is the only way. Nobody from outside can come and impose on a government to change a policy or a law. Nobody can impose a community to change their social behavior, whether it's female genital mutilation or gender-based violence or domestic violence or whatever. The real issue here, again, as you said, turning tragedy into opportunity. Service them for the tragedy first, give them what they need, but that tear in the normal social structure is an opportunity to empower women and other vulnerable populations by providing them with exposure to ideas, exposure to services, exposure. And just to give you beyond the example I said about Darfur and how today Darfur has tens of women's organizations as a result of all the disruption that happened in Darfur, and they're asking for their rights. Also, within the Ministry of Health today in Sudan, there are women who 20 years ago got exposed to ideas of rights who are now within the Ministry of Health. So by actually empowering local leaders, whether at the community level or ultimately some of them become in the national level, that's what you are going to do through integrating rights. Modeling high quality services, exposure to ideas, and creating the spaces for local people who are to benefit to actually find their own voice and find their collective power to make the change. That would be the formula for me.
Please.
I think the youth engagement is really important because most of the time in a humanitarian fragile setting, and there is a governance issue, and then governments are either overwhelmed or they are the part of the problem. And then also, community leaders, and then plus religious leaders. Well, of course, if the government is going to set the policy and registration and then the enforcement, that's the best. But we cannot wait until all of this, the conditions lining up. But youth, look at, yes, of course, there are different, the demography in the different countries. But Africa, that's a continent, the youngest. And then when, I'm just coming back, Haiti, so it says that in Haiti is also the 60% of the youth. And then I was talking to them, that they are saying they are completely different, the perspective, which I think I can see much, more hope. But within that, what also UNFPA is doing is that, we are talking to boys and men. We are creating we call, the initiative, so husband club and a boys club. And then we are, giving them opportunity to learn about women's, girls' body, how they can make contribution to ensure the rights and the dignity of the women and girls. But it's not only the rights, but also, that they have to understand how ensuring the rights of the women and girls contributing to their life and then to the society that they have to create together. So I think engagement of the boys, and so that's why I think it's good to have some men in the room, because I think there are even more you should be the influencers, and then you should be the leadership moving forward this agenda.
Thank you. Julie, you said a few things. I don't know if there's anything you want to add on that. Oh, we have a question. Please go ahead.
I'll just speak loud so everyone can hear me.
I think there's a microphone working its way towards you.
Thanks very much. With thanks to Dr. Tubia for highlighting the agreement on the need for SRH to be at the forefront of humanitarian efforts. My question is, from your varying perspectives, how do we get SRH to the forefront of humanitarian efforts?
Right, maybe we should take the second question and then give people the opportunity. There was a gentleman here. I don't know if you can get to him.
Different, so please go ahead.
All right, does anyone want to speak to that question?
I'll make a start at it. Thanks for that. So one push, strong push, is from the donor side, right? To earmark specific funding for sexual reproductive health in emergencies and demand that be part of their integrated health response of whatever actors are moving forward. I think it's still the case in some emergencies where we see that, there's obviously the cluster mechanism is set up in many of these situations, and you have the health cluster operating, but you don't have a whole lot of traction on the SRH subcluster, the sexual reproductive health, which is often and very well led by UNFPA in many settings, co-led with the Ministry of Health or other partners. But sometimes it takes months to see actors show up in that space. And by actors, I mean international NGO actors. It can take them a very long time. It's not that they haven't been operating quickly and with agility on the health side, but they haven't quite brought on the SRH element yet, right? It's not happening from the beginning. So I think one of the pushes is really to have that come from the donor side and in terms of supporting that. But it's also about investing in those who are already owning and working in the SRH communities. That is the platform of which IPPF member associations are. They are always bringing SRH to the table because that is their area of expertise and added, one of their added values to that space. And so they are going to continuously advocate for that to be brought. But there needs to be opened up coordination mechanisms that are more welcoming, inviting, and not just about sort of participation or meaningful participation, but frankly, leadership. That's what we should be aspiring for by the local partners in these forums. But that looks very differently in different contexts in terms of how we've succeeded or failed in truly integrating those local and national partners in those coordination mechanisms, where the plans are made, where the budgets are drawn, where the divisions are made, all of those things. So that needs to be something that we continue to push forward, because that representation will result, I think, in funding and action.
Quick to add, actually the good news, because I thought that was a very much a breakthrough. After the 2 years of the negotiation with WHO, now there is a SRH task team under the Global Health Cluster, which was established only November last year. So it's going to be automatic, systematic, that the SRH is going to be always included in any cluster system in a humanitarian setting.
Anything to add, or shall we move on to the next question? I recognize we're at time, but I'm hoping since we started late, we can end just a few minutes later, but don't hesitate if anyone needs to move on. Go ahead, sir.
Thank you. My name is Carsten Strandlod. I work for IFRC, the Global Reference Center on Mental Health and Psychosocial Support. Of course, sexual and reproductive health and rights should be at the forefront. So should inclusion. So should mental health and psychosocial support. So should a lot of other topics that are really, really important. In reality, we're competing. We're competing for the same funds. We're competing for the same attention. So the question is perhaps a broad one, but how can we join forces? How can we work together? Because we have a number of overlapping, especially between, as I see it, from MHPSS to sexual reproductive health and rights, and gender-based violence for that matter. How can we work better together to ensure that the sort of the pot of funding becomes bigger and used better? Because we are competing for the same funds as it is right now without cooperating. Thank you.
An excellent point. Go ahead.
Yeah, that's excellent. I think the only solution is that to think of human beings as complete human beings. They don't come to you hungry one day and thirsty another day and then needing antenatal care another day and then needing mental health another day. The person needing assistance is a holistic human being. And I think for us all to push that all humanitarian assistance should be more holistic. It may not happen tomorrow, but this idea of competing what? Shall we give them a little bit of flour and oil and whatever to eat, and then they go and commit suicide from just complete mental breakdown? It's crazy. So I think the whole idea is us here, or people in this the whole conference, has to realize people do not come with different bits of themselves. They come as complete human beings. And yes, mental health to me is just as essential as contraception and food and everything. So, and there is no reason why we can't do it holistically. Think of yourself first. You don't go and compartmentalize yourself. Therefore, we should not compartmentalize the way we support people.
I think the integrated programming is very, very important. The UNFPA, we, particularly in the difficult circumstances, we always use, of course not SRH, but the family planning as an entry point of everything, like Afghanistan. And then family planning is entry point of GBB, entry point. Actually, the MHPSS, psychosocial support, is the entry point, because Taliban doesn't really deny it. So I think we have the integrated programming, but women and girls comes to a facility, they get everything, the one-stop shop. So I think that's something that we all have to promote as a community. As I agree, you know, our body is one, and then we need a really comprehensive approach.
All right, we're wrapping it up. Thank you. Oh, another question.
Could I just add one more question? My name is Lisbeth Schokert. I'm working for DG ECHO, so donor. And we actually face quite a bit of challenges. I work in Central America and Mexico, based in Panama. And we actually have been pushing, because we're really convinced of putting more sexual and reproductive health in the package. But we have a challenge in finding partners. And secondly, we have a lot of operational challenges because we're focusing on migrants who are fleeing from the Darien to Mexico and the US border. Many women are victims of sexual violence, and they're on the route in a transit situation, undocumented, so they don't dare to go to local centers, and very often if we see them, because very often being invisible is their protection. So if we see them, it's very difficult. I mean, we see them for very short periods of time, an hour, a day, 2 days maximum. So it's also difficult on having like services that are meaningful when you actually see people for such a short time. And what we have today is very often we can only provide more adequate services once they are in Mexico because they are blocked there for long. But that's problematic because they have maybe been on the road for a... So we have operational challenges, and we have sometimes a lack of partners who are able to assist.
All right, I'm going to look at Julie, and I'm going to say, can you do it real fast?
I'll do it really quickly. Just to hear you on the continuity of care. And I think that is one of the things that IPPF member associations, because of the geographic presence that we have, we are able to provide those linkages for migrant routes, for example, from Venezuela to Colombia to Ecuador to Peru. And those are, and similarly out of Ukraine, through Hungary, over to Austria, into Germany. Anyway, it's something that they have been able to leverage the network to be able to share information, make referrals, provide continued support along those travels, and would be happy to talk with you more about that. Thank you.
Thank you, everyone, so much for your questions, for coming and spending time with us. I want to thank all of our speakers here on the panel today, as well as Olfat and Nicole, and our co-sponsors for the panel. Thank you very much for coming. Don't hesitate to speak to any of us if there's something you want to know more about.